Dr. Danovitch is the chairman of psychiatry here at Cedars-Sinai. He's also a good friend and a colleague, really a terrific speaker and a deep thinker about, in this case, the role of technology in engaging patients. And he'll be talking to us a little bit more about what is the role of these immersive technologies and how do these actually work with a sort of psychological perspective. So if you're ready to go, Itai, I'm going to get you up here, and thank you so much for your attention.
Great. Sounds good. First, I think we need another big hand for Brennan. He's a clinician, researcher, communicator, and now we have to add to all of that an event producer. This is an incredible event, the first of its kind at Cedars-Sinai, and it's a pleasure to be able to participate, to welcome all of you to Cedars-Sinai. My task is going to be a little bit more mundane than Brennan's. I would not characterize myself as an early or first adopter. I think I was at one of those early meetings 3 years ago with Brennan, and what I thought to myself when Walter and his colleagues came and showed us the incredible power of VR is, wow, this is cool. I want to do this more. I want to bring this home and show my kids what this is like, but how is this really going to help patients? And my own journey through this has been one of trying to grapple with questions related to that, and I'm going to touch on three things briefly. One is exactly how might VR work, or why might VR work specifically for medical applications, medical conditions. I'm going to briefly touch, really scratch the surface at a high level on the evidence for virtual reality. And then talk about some next steps and where we might go from here. And it's my hope that over the course of the rest of today and tomorrow, our presenters are going to unpack a lot of the details. But first, regarding the question of how VR might work, I thought we might do might generate a little bit of evidence of our own. And so I want to ask you to bear with me for a moment, very low tech. But I want you to bring your awareness to the door at the very front, my right, your left, of this conference hall. You don't need to look at it. Just bring your awareness to it. Notice it. Okay, now I want you to bring your awareness to the person that's sitting to your left. You don't need to look at them. Just bring your attention to them. Be aware that they're there. Are they a man? Are they a woman? Are they something else entirely? Is there anybody sitting next to you? And finally, bring your attention to your feet. Notice your feet, the sensation of your socks if you're wearing them, your shoes, the floor underneath them. Who was able to do that? Please raise your hand if you were able to do that. Just about everybody. And some of you didn't raise your hands. Perhaps you were distracted. Perhaps you were looking at your devices. But what I would suggest to you is that was proof of an ability that we all take for granted, the ability to manipulate our attention, right? Very simple and straightforward. Ability to move attention from one thing to another. Attention is a spotlight, as Brennan said. And it's under voluntary control and involuntary control. Managing our attention when we're calm is relatively easy, managing our voluntary, but when we're in a state of stress, or more than stress, if we are distressed, if we are in pain, if we are frightened, if we feel threatened, as Brennan mentioned, we have 900 or so patients, up in this hospital building up above us in various states of feeling frightened, feeling that their body, that their well-being is threatened. And is it possible for them to manage attention in the way that we just did? Yes, it is, but it gets harder. It gets a lot more difficult. Voluntary attention is really subject to distraction, right? We turn away, we get distracted, and involuntary attention is really subject to our emotions and our affect. Our affect, our emotional states govern our attention more so than anything else. And at least one of the many powers of VR is its ability to reach through the noise and to govern our attention, right? And in so doing, to govern our cognitive apparatus, our minds and our brains, and orient it in a number of, towards a number of applications. So what can you do with that? VR can bring our attention to something other than what we're doing to distract us, which can be really positive if we have a disturbing stimulus that we're trying to avoid. We can use VR to bring attention to a disturbing stimulus so that we can desensitize to that stimulus. We can use virtual reality to bring sustained attention to skills and tasks such as visual spatial tracking, to motor coordination, or more complex functions like role-playing, or perhaps even self-reflection. I would posit, way oversimplifying what VR does, that there's at least three major kind of buckets. One is it grabs our attention and places it in places. Two is in grabbing our attention, it allows us to practice skills, a wide range of potential skills. And three, and I think the third relates to what Brennan was referencing in the experience of stepping out of virtual reality back into reality, is that it causes, or it is a tool that can be used to cause self-reflection and awareness of our own subjectivity. And that may have some of its own benefits and applications. So Coleman Glantz and colleagues 20 years ago, in exploring the potential role of virtual reality for psychotherapies, wrote that one reason it is so difficult to get people to update their assumptions about reality, is that change often requires a prior step. Right? And they're talking about change because most psychotherapies are trying to alleviate suffering or trying to create well-being by facilitating change around cognitions, emotions, behaviors. Recognizing the distinction between an assumption and a perception has to happen before change is made around an assumption. And until revealed to be fallacious, our assumptions about the world constitute the world. They seem like perceptions, and as long as they do, they're resistant to any kind of change. So at least one power of VR is the ability to make us aware of our own subjectivity, and the ability in a profound experiential sense to help us recognize that what we take to be reality is so easily manipulated. And I sat on that, or stood on the scaffolding, and was told to step off as well. And as I took off the virtual reality goggles off of that experience, what really blew my mind and humbled me was how easy it was to completely alter my sense of what was real. Okay. Now the process of taking a innovation, a new tool, and determining whether that tool that is engineered, that is innovated, actually has a role addressing a clinical phenomena, a phenomena that troubles a patient, and then testing that tool to determine if it actually helps a patient with a disease or condition, and then rolling that out to a broad number of patients and to a population to improve health of people at large is called translational science. And the state that I think we're in right now with virtual reality is really around kind of the first and second phases of translation. How to take this incredibly innovative and powerful technology that appears to have roles for a wide variety of conditions and types of patients, and actually use that technology to have a meaningful and significant impact on the conditions and diseases that afflict patients. So the process of answering that question, and I'll take a few moments to cover what we mean when we talk about the evidence for VR, because we do have a heterogeneous audience with everything from scientists to laypersons, is a series of studies that try to answer questions about who exactly benefits from VR, and in what particular way. How do they benefit? What's the right setting? Where? Is a hospital, how is the hospital setting different than the home setting? When? And what's the duration and dose of exposure to VR that's helpful for a particular condition? Why? Why does it help? And how can we use an understanding of why to better inform our interventions for VR? So we take studies that address these questions, and then we have a a system of categorizing the quality of these studies so that we can understand how valid their conclusions are. And so there are several tiers of evidence that you can use to characterize evidence. One is, the most common basis of evidence, but also the most subject to bias is expert opinion. Then you get uncontrolled studies. I was just talking to somebody in the audience who mentioned that he was using VR to deal with some procedural pain, but then once having that headset there, it was attractive and easy to use it for a whole variety of other conditions for which it seemed to be helpful. Right? So those are kind of uncontrolled studies and a lot of anecdotal evidence that we have and that exists throughout the room among our audience members, particularly those that have tried and sampled and given patients or subjects VR. And then we have uncontrolled and controlled studies, and then systematic reviews and meta-analyses. And systematic reviews are the highest form of evidence. They are studies of studies. Of course, they're only as quality as the studies that go into them to begin with. But it's systematic reviews of studies that ultimately start to inform practice. So I ran a search in preparation for this of all studies in a large medical database that use the keyword of virtual reality. And this shows what many of you know, which is that at some point in the mid-1980s in this database, the term virtual reality was first published as a keyword, and that there's been an incredible acceleration of studies that reference virtual reality, where there are almost 1,000 papers in this database per year now that are referencing virtual reality. I then subject this search to a couple constraints. First, I constrained it to clinical trials, and this orange line below the blue line represents all the clinical trials in virtual reality, and you can see that we're now at the pace of about 100 per year clinical trials in virtual reality. And then the gray line at the very bottom represents systematic reviews of virtual reality. So that's the studies of studies across particular sets of conditions, types of problems, types of applications of VR. And what I want to do next is take you through, survey style, very high level, what some of these systematic reviews show across these conditions, 5 broad conditions. One is acute pain, and probably the condition for which the applications of VR have been best established and are most compelling is acute pain, particularly burn pain. This is an individual who's getting a procedure or dressing change, who's a burn victim. And then a variety of other psychological factors that impact pain, distraction, general pain reduction. The effect of VR in addressing short-term acute experiences of pain is really quite powerful. Second, psychiatric conditions, particularly anxiety disorders. This is what you see over here on the right-hand column, and you guys should have a way to access these slides, and if not, you can, I can get them to the conference coordinators. I have the systematic reviews for each of these conditions listed so that you have an easy way to access them. But treatment for most anxiety disorders, there is somehow a disproportionate fear response to a otherwise non-threatening stimulus. And VR is so powerful because it can, in a safe environment or in a controlled environment, it can facilitate exposure to that stimulus while a variety of skills are learned or trained or developed to deal with that stimulus and manage the fear response in a more adaptive way. And so specific phobias, right, a phobia, fear of a spider, of heights, of a snake, is the condition for which that is kind of most simple and straightforward. PTSD clearly is a very complicated and multifaceted condition that involves a fear response to a unthreatening stimuli based on past traumatic experience. Anxiety disorders and whatnot, these are conditions for which the power of VR is really significant, particularly as an augmenting agent, an agent that helps to enrich the therapy experience to create an exposure that's very realistic. None of these conditions yet have fully packaged interventions that can be offered to patients, to my awareness, without the role of a clinician helping to manage the response to this in a clinical setting. Addictive disorders, where there is a trigger for a craving response with a behavioral repertoire that follows that, and so forth. There have been quite a few systematic reviews and studies of virtual reality for a variety of neurological disorders, including cerebral palsy, Parkinson's disease, multiple sclerosis, memory disorders such as Alzheimer's, upper limb function, and also particularly for post-stroke rehabilitation, where it's necessary to bring sustained attention to very difficult and specific tasks. And VR seems to be very helpful in helping patients to do that, and in so doing, helps to improve a lot of post-stroke outcomes and recovery. And then for general rehabilitation, particularly for balance, for mobility, for broad physical function, and other applications. So we did a systematic review. Our group, Brennan mentioned this. What we asked is, what is the evidence for the efficacy or effectiveness of virtual reality used in hospital settings such as ours? And so what we did is we conducted a literature search over a period of time in several databases. We generated a bunch of papers, manuscripts that met our inclusion criteria. We then subject those papers to inclusion and exclusion criteria, ultimately generating 11 studies that met the criteria that we established for this. Here are those 11 studies, and here's what we learned. We learned that most of these studies addressed pain, procedural type of pain. 5 studies had to do with alleviating pain symptoms associated with burn, particularly dressing changes. There was also cancer pain, physical trauma pain, and then a study on obesity, a study on stroke rehabilitation, and a study on traumatic brain injury. These are controlled clinical trials in the hospital setting. We also found that across these 11 studies, there were 13 different scales that were used to measure and assess the outcome of the VR intervention. And that may sound like a good thing. It's nice to have a lot of, but imagine trying to judge the performance of an Olympic event, by 13 different measures of performance for that event, right? It would be impossible to know who won or to be able to compare one competitor to another. And this is one of the challenges in the field. It's very heterogeneous. We have a lot of groups that are developing their own measures. And so it's very difficult to make comparisons even for the same condition across different studies. Ultimately, what we learned is that VR has been shown to meet its endpoints in each individual study by and large in the inpatient setting. It was well tolerated in most studies. However, the studies were small and heterogeneous, which means that they were of low to moderate quality and highly subject to bias, and that there's certainly a need for larger, higher quality studies. So does VR really help patients? I would say that what we know now is it's a compelling intervention that's highly versatile. It's evolving incredibly rapidly. There's a broad range of potential indications, and the indications which are best established at this point involve managing acute distress and or developing discrete skills. Most of the studies that exist in this space, if you look at those systematic reviews which suffer from some of the methodologic quality of the studies that underpin them, have moderate to high bias. Where there is benefit, it appears often to be supplemental benefit to an existing treatment and or kind of comparative benefit to an existing treatment, but in no case that I'm aware of necessarily superiority to other evidence-based first or second line treatments for conditions. It is, however, has a huge benefit of being well tolerated and safe across most conditions. What are some questions that we have? Well, is VR an intervention in and of itself, or is it a vehicle to deliver other types of interventions and experiences? What are the essential components of virtual reality? Is it the hardware? Is it the software? Is it the dose and duration and the intensity? Is it some combination of all of the above? What is the role of the clinician? Do we need a clinician? Can we have a technician? Can patients do this on their own? For what conditions do we need a clinician? And how do the answers to these questions vary by indication and by patient? Finally, as Brandon Burkhead will tell you about tomorrow, how do we improve the science and evidentiary basis of VR so that we collectively can do a good job of answering these questions? And finally, what concerns me is in an era where each of us are confronted by the distractive power of so many devices that stand to pull us away from our engagements with each other and our relationships. How do we develop VR in a way that keeps the patient at the center and that extends, that amplifies the services that we're giving to them without putting other types of walls, digital or others, between ourselves as clinicians and providers and our patients. So with that, thank you, and have a wonderful conference.